Good morning.
I hope that everyone is doing well.
Yes,
So,
good morning,
yes,
ma'am.
we
Yes,
are.
ma'am. Good morning.
thank you very much. So, yesterday we had a very interesting session, 2 different presentations, one on genetic counseling processes in sickle cell disease, and use case studies to understand how to go about genetic counseling. And then we also talked about the documentation and referral processes in genetic counseling. And so for today too, we have 2 very stimulating presentations also for us for the next 2 hours. And we'll be talking about sickle cell disease in pediatrics and genetic counseling, which will be ably done by Dr. Ofakunrin. And then after that, we'll also listen to psychosocial and ethical considerations in sickle cell disease. And Prof. Adejumo will do as that honors. And so we'll start by introducing the 2, speaking about the profiles of the 2. But before we go there are a few housekeeping that we want to also put up across. That anytime you join, I know that people drop off and on. Anytime you join, make sure that you mute your microphone so that you don't disturb others as presentation is ongoing. And then a poll will also be launched for you to fill your attendance at some point in time. Everybody is expected to fill their attendance, and so please make sure that you fill the attendance. And then I've seen that people were asking about the presentation slides. All those will be available to you, will be sent to you so that you can have them and use it to revise. Okay, so let me go on and then talk about the profile of our 2 esteemed presenters. So the first one is Dr. Akinyemi Olubenga Ofakunrin. He's a consultant pediatrician and associate professor of pediatric hematology at Jos University Teaching Hospital and the University of Jos, Nigeria. He serves as the Research Fellows Coordinator for the Sickle Pan-African Research Consortium Nigeria, that's PACNET, leading capacity building efforts for emerging sickle cell disease researchers nationwide. Dr. Ofakunrin has over 15 years of experience in clinical care, teaching, and research. He is a JUTH site lead for the SPACNet and Accelerate project and oversees care for more than 1,200 SCD patients. His work focuses on improving sickle cell disease outcomes by expanding access to hydroxyurea and integrating comprehensive care models. As a Fogarty and Marie Sklodowska-Curie Fellow under the EU-funded ARISE program, he has received training in SCD care and clinical research at leading UK institutions. And so that is the bio for Dr. Ofakunrin. We'll go ahead and also listen to Prof. Adejumo. So Prof. Adebayo Adejumo is a multidisciplinary with his professorship in health psychology and bioethics. He was a member of the technical committee that developed the Nigeria National Code of Health Research in 2006, and also served as a member of the National Health Research Ethics Committee for Nigeria for 11 years. He is a laureate of the Union for African Population Studies, a recipient of Fogarty International Scholarship in Ethics, and also a bioethics intern of the National Institutes of Health in Maryland, USA. Professor Adejumo is a fellow of the Nigerian Psychological Association and also a fellow of the West African College of Nursing. He is an executive committee member of the Nigerian Developmental Psychologists Association. Prof. Adejumo is a chair of the Social Sciences and Humanities Research Ethics Committee, University of Ibadan, and also the chair of UI Ethics Policy Review Committee. He is globally traveled and has over 70 publications in peer-reviewed journals. He is also the co-PI of the NIH SURER grant of the University of Ibadan, a foundation member of the Center for Bioethics and Research, and co-founder of the Focusing on Young Nurses initiative, with members across 3 continents. And so we have the honor of having these 2 esteemed presenters to speak to us today. And so at this time, I think I will stop sharing and then let Dr. Ofakunrin take the stage as he presents and give us our first presentation. Welcome, Dr. Ofakunrin.
Thank you very much, Dr. Vivian.
Thank you too.
Yeah. Okay, now sharing my screen. Okay, good morning, everyone. It's my pleasure to be here
morning, sir.
this morning
Good morning,
to
sir.
make this presentation. Thank you very much. To make it this presentation on sickle cell disease in pediatrics and genetic counseling. I know that we've started this series over some weeks, and we've heard a lot about genetics, the clinical manifestation and complications of sickle cell disease from various speakers. But this morning, I want to show us how sickle cell disease uniquely affects our youngest patients, that's the pediatric population, and how genetic counseling can change the story positively. So that's what we're going to be discussing in the next 40 minutes now. So under these following objectives, I would like to describe how sickle cell disease presents in children. So meaning that, there was actually a prior lecture taken by Dr. Isa that all the clinical manifestations and complications, both in adults and children, everything were discussed. So, but today, we're just going to focus on some peculiarities in children. So, and secondly, on the importance of early diagnosis and intervention, which is very, very important and a big game changer. So, and also to explain the role of genetic counseling in pediatric sickle cell disease without repeating what we've been taught, and even especially yesterday. And for us to be able to support families through effective communication and collaboration. So, well, I'm going to start with this case study. Sometimes back, like about 2 years ago, a mother brought her 2-year-old son to our clinic. The child had painful swollen hands and feet, which we call dactylitis. So she thought initially that it was a spiritual attack, or maybe the child was reacting to something, probably that he heard. The child was in pain, cried all through the night. The fingers were swollen and very painful. And no one in the family knew that he had sickle cell disease. Even those around, the neighbors, they don't know. So, and this was the first episode of crisis that child will have. So on account of this, we decided to run some tests. And when the diagnosis came, it was obvious that it was sickle cell anemia. So the mother was shocked. So both the mother and the father, they didn't know that they were carriers. So no one had told them before. They've not done any genotype testing, no prenatal counseling, no neighbor screening. And what the mother said actually stuck with me. That she said, if I had known, maybe I would have done things differently. I want to tell us that this birth story is not rare, and we are all familiar with this in one way or the other. So, and that's the reason why today we'll be focusing on how sickle cell disease presents in children and how genetic counseling, if done early, can help family like the boys make informed choices and receive timely care, which is very, very important. So now, talking about the clinical manifestation in children. So what are those things that are actually important for us to know among children, as in what is peculiar to children? So the reason why we're going into all this, you know that the manifestation of sickle cell disease starts early. And most times, this is actually not being recognized. We will have been having crises, moving from one place to the other and all those stuff, and having some subtle signs, even if not bone pains or dactylitis. They are not diagnosed until 3 years of age, 5 years of age. And at that time, even some complications will have started setting in. So in which case, it makes the outcome not to be too great. Unlike when diagnosed early. Although the best is for us to do newborn screening and pick them even from birth. But since we know that newborn screening is not still widespread, so we, doctors, nurses, healthcare workers, and even the genetic counselor, at least we relate with people around us. So we should be able to have the knowledge, the requisite knowledge, so as to pick these conditions early and refer appropriately or act appropriately so that the outcome can be great. So now, having said that, so one of those first signs in children is actually what we call dactylitis, that is described as hand foot swelling, which you can see from this picture. So that is one of those first manifestations. So that if you see any child with, that was having pain, having swelling of the finger, the hands, or the feet, just add that high index of suspicion and let them just go for genotype testing. So, and it's been said, some studies have actually found that early dactylitis occurring before the age of 1 year, could actually be a predictor to severe disease later in life. Although that was actually the finding from cooperative a study of sickle cell disease that was done in Jamaica. So, but some other studies have also found that, well, with some other modifications, it may not result in severe disease later. So, but this is high index of suspicion for us to be able to pick early and do something appropriately. Then the second thing is anemia. So, for instance, you have a child, maybe just incidentally, you just did some full blood count, or you decided to do the PCV, a 2-year-old child, a 3-year-old child, and you discover that, or 1-year-old, that the PCV is less than 30. That should actually be a red flag, because the child doesn't have any business of having hemoglobin less than 10 grams per DL. So that if you see such, even without any dactylitis or some other manifestation, that should prompt us to say that, let's do the genotype. Other things can be responsible, but sickle cell disease in our environment, in sub-Saharan African countries, in Nigeria, in Ghana, will actually be a great consideration. Then other manifestation that they have is infection, having recurrent infection. And this has actually been attributed majorly to streptococcus pneumonia, that's pneumococcal infection. And that's part of the reason why we talk about, giving penicillin prophylaxis and also vaccination against pneumococcal organism and some other organisms that they are susceptible to, mostly what we describe as encapsulated organisms. So then what other manifestations do they have? Sorry, my slide is not moving. Okay, so this fine. I think we are good to go now. Okay, so then those are as in common early manifestations. Then at times too, we can be talking about jaundice. They can also have jaundice. Then also some early complications that is common in pediatrics. There are so many complications. So, but I will just pick these three. The acute chest syndrome is actually a common complications that they have, in which case they have fever, some respiratory symptoms, cough, chest pain, difficulty in breathing. When you do the oxygen saturation, you discover that the SpO2 is low. So, and majorly, very importantly, doing the chest X-ray, then we find from the chest X-ray that there are infiltrates on the lung, in the lung fields. So with that, we make a diagnosis of acute chest syndrome. So it's actually is one of the commonest causes of death in them, in addition to infection as well. So it's something that, it manifests early as well, and we need to have high index of suspicion, treat appropriately. Then also there's the aspect of stroke. Okay, about acute chest syndrome, yes, it's commoner in children, but it's more deadly in adults. So then the other one is stroke. Yes, the commonest cause of stroke in children. So if you see any child with stroke, before you think about any other thing, because we know that stroke is actually associated with adults, hypertension, diabetes, and so on. But children also can have stroke. So most times, the reason for stroke in children, there could be different causes, but the most common cause is sickle cell disease, so that they can have stroke and they can have it at any time. It's as a result of, the commonest one that they have is the ischemic stroke as a result of obstruction in the cerebral vessels. So that's giving them that. So we also need to have high index of suspicion. From my practice, we've actually seen patients that had stroke, but because it's not common in children, that the parents didn't recognize that. They took the patient to some peripheral hospitals. Even the doctors there could not recognize that. So I know that there's actually like a sort of an acronym that is being used in the UK and is available online that is called FAST. So that is talking about the fascia, the face, the arm, and so on, that you can actually use to determine that, oh, there's stroke. So facial deviation of the mouth, weakness of the limbs, and so on. So then the other thing that they can have is sequestration crisis. This occurs when there's pooling of blood in the spleen, although it can also occur in the liver, and is very deadly, such that it presents as if the patient has shock, and if something is not done, the patient can die. So all these are important. That is expected that as health workers, when they come to us, we should be able to, as a right from even infancy, make sure that we do abdominal palpation, check for the spleen to see that there's no enlargement of the spleen, and even teach the mother how to do that, so that, because if picked early, things can be done and the child can survive that. So now I've talked about, some of few early signs and some complications that are common with them. I'm not exhausting everything. There are so many, but some common ones. So another thing that is also important in pediatric sickle cell disease is about growth and development. Why this? Is because, children are still growing, and with sickle cell disease, it tends to affect their growth and development. Unlike adults that are adult, they've already grown, but meanwhile, they will have been impacted too during childhood. So the reason why we're doing all this is for us that if we pick them early and we understand the natural cause of sickle cell disease, then we'll be able to impact them positively and mitigate some of these problems. So it can affect their growth in such a way that they have delayed height and weight gain, failure to thrive, delayed puberty, which actually has some significant psychosocial effects. You're in the boarding school, you're in GS3, most times by the time you are getting to SS1 or even coming to GS3, you discover that your colleagues, they have the secondary sexual characteristics have developed, and you don't have that. So that we should know, so that one, we'll be able to, if that occurs, we'll be able to counsel them and support them appropriately and let them know that it's just a matter of time they will have it. So that's number one. Then the second aspect, which is important, is that if we intervene early, you discover that the impaired growth will not occur. For instance, in my setting, we've actually started using hydroxyurea for some time now. Prior to hydroxyurea, if you come to the clinic, before without anybody telling you, you know that you are in sickle cell disease clinic. The sickle cell habitus, that's the facial appearance, you know that, oh, this sickle cell patient, this sickle cell patient. Then also, maybe this one is in pain, this one is in crisis, the eyes of this one is yellowish, and so on. But with the advent of hydroxyurea and more knowledge, training the mothers, telling them what to do, good nutrition, and so on, you see so many of our patients, the growth and the development, they are plumpy, they are fine, they don't have the sickle cell habitus. That is part of what we're saying. That understanding this, intervening early, can make a lot of difference. So what other ways does it affect? So they also have reduced physical stamina. They get tired easily. They have exercise intolerance, because of the chronic anemia that they have. Then they can also have some neurodevelopmental delays, like cognitive impairment from silent stroke that they have, so that they may not perform well in school. We also know too that there are some of them that are very excellent, that they perform excellently well in school. So, but if for those that have cerebral infarct, it will affect their academics. Knowing this will help us to support them, give them additional support, and they will be able to do well in school. Then they can have learning difficulties and poor school performance, especially as a result of frequent school misses and so on. Then the psychosocial impact. Yes, I'm not going to dwell so much on this because that's what Professor Adejumo is also going to talk about. So, but I will just mention that, all these problems tend to make them to have poor self-esteem, social withdrawal, and frequent school absenteeism. So, we need to understand this and support them appropriately so that the outcome will actually be great. I know that in many settings in Nigeria, both secondary school and universities, a sickle cell patients will miss school, and the lecturer will still be hard on them and not making appropriate adjustment for them. So we experts, these are some of the things that we should take up and take up with different authorities and let all this be addressed. So having said this, it's not compulsory that all that I've said, manifestation, complications, growth and developmental impact must happen. We can mitigate them by early intervention, and that is the cruise of this discussion. So what are those early intervention opportunities that can help mitigate what I've said early? Number one, newborn screening. Once we detect them early, pick them at birth, then we can actually start penicillin prophylaxis as early enough, even from 2 months of age, and start vaccinating them against some of those general vaccination according to NPI schedule, Nigerian program on immunization, although the Ghanaian too, they have their own. So that's general one, and some specific ones that are unique to sickle cell disease, like the pneumococcal vaccine, Haemophilus influenza, covering against all those encapsulated organisms. Then, for us to be able to give them nutritional support and monitor their growth. With that, we have patients in my clinic that are growing well, that even at 12, they started developing secondary sexual characteristics, breast, and so on and so forth. So that you discover that the psychosocial complication will be taken care of. Then, more importantly, early hydroxyurea use is been recommended by the NIH expert panel, and that is what we are using, like in my setting, and that is what the guideline, because currently we're in the process of developing or trying to revise our guideline in Nigeria. So that's what also we've recommended, that all children with sickle cell disease, starting from the age of 9 months, should be offered hydroxyurea, so that irrespective of the clinical severity, either they've started having crises or they've been very stable, let them have it, because it tends to reduce complications for them. So, and more importantly as well, we need family education and routine follow-up. Educate them so that they'll be able to care for the children very well, and educate them so that also they can actually have some psychological balance to be able to weather the storm. And with routine follow-up, not just following them up that they come to the clinic, oh, I've seen you today. No, when they come to the clinic, we check them generally at the younger age, prepare for the spleen, check the growth, check so many other things, then do some tests that could actually help to screen for complications. Like, for instance, transcranial Doppler ultrasound is expected that all of them should have it annually between the age of 2 to 16 years. And those that have the range values will be monitored more frequently. And some other organs complication, so that we monitor these. Once they are detected early, we can intervene and prevent it from being full-blown. So all these are important. There's still so many things to talk about, but we just have to summarize it and package it like this. If there are some other things regarding that, we can take it during the Q&A session. So now, the second part of the lecture is about the role of genetic counseling in pediatric sickle cell disease context. So what's the role of genetic counseling? So I want to start at when and where genetic counseling fits in. This have been said again and again. I just want to pick out the aspect that is related to pediatrics. So there's the preconception or antenatal counseling. We actually love the preconception, even before talking about starting relationship, before talking about marriage. It's not when marriage is about 2 weeks to take place. That's when you now do the screening and you now discover that this one is AS and the other is AS. You won't be able to, you've already sent invitations to everybody. You've already prepared everything for the wedding. So it will be difficult to call off the wedding. So we actually prefer that, even apart from picking it at the newborn screening level, we can also do this, the genetic counseling and testing at, secondary school, so that let them know, university, before you start a relationship, before the love sets in, that, oh, I'm AS, then what's your own genotype? You're AS. No, we can just only be friends. We can't have more than that. So all these things are very important, so that's part of where our genetic counseling fits in. Then newborn screening. So before newborn screening is done, we have to do genetic counseling, and after the newborn screening. Now, more importantly, we have so many patients that already have sickle cell disease. So there should be ongoing support for decision making on how to care for the child, then also out for family planning for siblings and future pregnancies, how to go about it. So all these things are important. We know that there are options that are available, but that are very expensive, like pre-implantation genetic diagnosis that can solve the problem, and the IVF option and so on. So, but all those things are what we should know and be able to offer them. So now, how do we genetics counseling? How do we support with genetics counseling? How do we go about that? All these, I'm repeating them again just to emphasize the knowledge. Yes, it's been said yesterday, so that we understand the inheritance patterns. Is very important for us to know that, so that we'll be able to counsel them appropriately. Then to help families understand the child's condition, help them to make informed decision. It will help in informed decision making. Then the genetic counseling that we're doing will be able to help us to offer emotional support and assist them in managing stigma that's associated with the condition. So, and in doing all this, there should be the cultural considerations that we have in Africa settings. So now, the last part of our discussion. Usually, you discover that the parents, they tend to actually, either when the diagnosis is actually just made, or even with ongoing treatment or ongoing care for the child, there's actually this aspect of parental guilt, fear, and misconceptions in sickle cell disease. It's expected that our genetic counseling, we should be able to address some of these and communicate effectively with them. Like some 3 days ago, there's one of my patients was actually admitted at the emergency care unit. So both parents were on ground. Then the father sought audience with me, was actually telling me about things, how up to now. The diagnosis has been made long time ago and the child has been receiving care. That up to now, it was actually still feeling guilty, feeling bad, that it was that they caused this and so on and so forth. In such a way that the psychological burden that they bear, the guilt is actually like really overwhelming. Even to the extent that, some of them, as in considering some other things as per, okay, according to him, it's making him to be depressed and for some time, even tending to affect his blood pressure. Well, I'm just quoting him. So we need to support these parents. It's just one that can come out and express himself. There are some other ones too that are also suffering in silence. So all this need to be addressed. And that's why we're having this, so that we can be empowered with how to go about them. So it's expected that in whatever we do, that we provide clear and compassionate education. Make sure that you put yourself into their shoes and talk to them compassionately. So that we need to explain the genetic basis of sickle cell disease so as to help to dispel the blame and guilt. You understand? So yes, the children, not that they decide to choose it by themselves. And even most of the parents, they never knew their genotype even before marriage. You understand? So there may be few ones, they knew the genotype 2 weeks to the wedding. It may not be easy. And even those few ones that knew their genotype and the consequences, and they still went ahead, that doesn't mean that they must be overtaken by blame and guilt. So that we need to emphasize the inherited nature of the condition and to let them know that it's nature, it's inheritance, it's hereditary. So it's not that you knowingly afflicted, sickle cell disease on your child. Then it's also very important. These are the tips that we need to use to normalize their emotional reactions so that to acknowledge and validate their emotions. Let them know that, the way they are feeling, the fear and the guilt that they're experiencing is common to many of the parents, or even almost all, and that is understandable. And to be able to still let them know that, well, yes, what has happened has happened. And at least I want to believe that if they have the power, they would not have allowed it to happen. So what you don't have control over, then you don't allow the fear and the guilt to overcome you, but rather to look for the solution. So, and it's also very important that we address myths directly so that we'll be able to correct harmful beliefs about sickle cell disease. Some people believe that, in some culture, in some community, that even those children are witches and wizards, which is not true. That they are curses, they are sent to the family so that they can drain the wealth, so that, they can, inflict, they cause affliction in the family. All these things are not true. And some believe that it's a spiritual attack. So that we need to use culturally sensitive language and evidence-based explanation to let them know that that is not sickle cell disease. It's just an hereditary condition that has occurred because, your genotype is AS and another genotype is AS, and you come with SS and some other genotype combination. So very important that we do that. So now, and it's very appropriate that we empower them with knowledge and skills that they can use to care for the children. So that let's focus on what they can do. Like if the children are sick, they should come promptly to the hospital. I normally tell my patients, they have fever. So it's not the one that they are not the type of children that you say that, oh, let me observe till tomorrow. That tomorrow may be too late. Bring them immediately. Early intervention in even medical care generally, once anything is dictated, either sickle cell or non-sickle cell, prompt diagnosis actually usually brings about great outcome, even including in cancer cases. Early diagnosis can actually help to achieve cures in some instances. So, and the same thing for sickle cell disease, although I'm not talking about cure, but I'm talking about great outcome. Then to empower them that they need to come for regular checkups when that at least to keep to their hospital appointment. And we health workers too, let's make it a worthwhile for them. Let's make it worthwhile for them so that when they come, at least we give them attention and be able to check appropriately. Not that it will just be something routine and at the end of the day, we're not actually impacting anything positively on them. So the aspect of the good nutrition, we need to let them know that good nutrition will make a lot of difference, and medication adherence, folic acid, penicillin, and especially hydroxyurea, so that let them know that they should support the children to take their medication. Then we can also provide resources and local support group information for them so that they can associate with others, learn from others. Then other tips for addressing, the parental guilt, fear, and conceptions in sickle cell disease. Let's use real life stories that we should share the success stories of children thriving with sickle cell disease so as to instill hope in them. And not only even those that have passed through that, even some adults. For instance, we have, adults with sickle cell disease that they are doctors, they're lawyers, they're engineers, and they are doing well. We have so many, that have families, they have children. So these are part of the stories that we can use to encourage them. We are not just deceiving them or flattering them. They are real things that will encourage them for them to push on. Then it's also important for us to engage the fathers and the extended family. You discover that most times, once that happens, the fathers will just leave, the mother to continue to take care of that. You discover that clinic day in and out, there is only the mothers that will come. When they are on admission, just only the mothers that you will see. And even in some instances, some fathers, as in some husbands, will just decide that, okay, I'm done with this marriage, we can't continue. So, meaning that even sickle cell disease disproportionately impacts women negatively. So, but we can actually play a role here so that we invite both parents, educate them. Education will bring power, will be able to empower them, then give a change of mind so that they will be able to be very supportive and care for the children appropriately and support their wives. Then it's also important that we offer ongoing psychosocial support. As I said earlier on, Professor Adejumo is going to talk more about the psychosocial aspect. So, but just to say that we need to refer, if it's overwhelming, we may need to refer them to counseling or support group. So like the patient that I mentioned, I actually did some counseling and I plan that I'm going to involve a clinical psychologist because it's actually affecting the health of the man. So that clinical psychologist will also play a role so that we can have a good outcome and, it will be in a good stead to support the affected child. So with ongoing psychosocial support, it helps to promote resilience and family-centered care. And with family-centered care, that the family members are showing love, they're showing care, they're very supportive. Then the psychological impact and the emotional burden of sickle cell disease on patients will be significantly reduced because you know that you have a loving family that are supporting you. Even that will boost your confidence when you go out so that you won't just, accept discrimination or stigmatization from anybody to weigh you down. So having said this, it's important that we work together, across disciplines so that pediatricians work with the counselors, with the nurses, with the lab staff, and even with the adult hematologist, so that by the time we are transiting them to adult care, so that the transition will be seamless. It's not the one that the pediatrician will start hydroxyurea and the adults, when they get to the adult clinic, it will be stopped. So that let's all work together. So, and I've said earlier on that linking families to support networks and community resources is great. Seeing others the way they do their things, listening to the positive aspect of what is happening to them, and learning from some negative aspect of what has happened to them will also help to care for the children appropriately. So, and it's very, very important, lastly, that we keep on reinforcing counseling messages during routine visits. Any aspect, reinforce it. Talk about some other things, and let us always be mindful of the mental health of the patient and the parents. So, in conclusion, and this is my take-home message, when we talk about pediatric sickle cell disease, it's not just about caring for them symptomatically and treating them, but it's about futures that we're trying to shape early, so that future in the physical health and even in the psychosocial aspects of their health. So with early diagnosis, family-centered care, and effective counseling, you discover that you will not just only be managing sickle cell disease, but you help the entire families to thrive. So thank you very much.
Thank you very much, Dr. Ofakunrin. That is very great presentations. So there are lots of questions in the chat box, but we'll just discuss all of them at the end. So can you please unshare for us, Dr. Ofakunrin, so that Prof.
All right, thank you.
Adebayo Adejumo can also come. Okay. So our next presentation will be by Prof. Adejumo, who will be speaking about psychosocial, legal, and ethical considerations in genetic counseling for sickle cell disease. So we'll welcome Prof. Adejumo to do us that honors. Welcome, sir.
Good morning.
Good morning, sir.
Can you hear me?
Yes, I can hear you.
I want to be sure I'm audible.
Yes, you are audible. We can hear you.
Yes.
Good morning.
Welcome,
It's my pleasure to be with you, but I want to be sure that the slides are also shown. Okay.
So please, can you put on slideshow for us?
Can you see the slides? Are the slides showing?
Yes, the slides are showing. And if you can put in the slideshow mode so that
Just
it's
hold on
bigger.
a little bit.
Okay, thank you.
Okay. 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 So, good morning, everybody. It's my pleasure to be with you. And I want to appreciate the organizers for putting together this think tank, and also for counting it worthy to ensure that people can come to share their resources, their wealth, their experiences with a brand new generation that will carry the gospel of management of sickle cell disease to a much enviable or more enviable height. So today, as you can see, I'll be speaking on psychosocial, legal, and ethical considerations in genetic counseling for sickle cell disease. Along the line, I'm going to talk about what we really mean by those psychosocial issues. I'll try to separate this from legal issues, and I will dovetail a little more on ethical considerations as we proceed. And my attention towards the end of my presentation will now focus more specifically on the issue of genetic counseling for sickle cell disease. What are the ethical issues? What are the psychological issues? what are the social issues, and what are the legal issues that we professionals should consider when planning and dispensing, genetic counseling, especially for patients and their relatives, especially within the ambit of sickle cell disease. We need to know that sickle cell disease, by way of reminder, is a hereditary blood disorder. It is characterized by abnormal production, and this result hemoglobin production, and this could result, many times do result, in chronic anemia, and oftentimes there are vaso-occlusive episodes, and this could, by extension, lead to organ damage. The kidneys and many other organs of the body could be affected. It's also needful for us to know that the two countries that are being considered in this workshop, in this conference, do I mention Nigeria and Ghana? They have so much of prevalence when it comes to the occurrence of sickle cell disease in our generation, in our population. And of course, specifically Nigeria as one of the highest global burdens, figures, prevalence of sickle cell disease. And of course, these now make the need for genetic counseling very imperative in an attempt to be able to reduce the chance of replicating the transmission of the gene in new generations. And of course, talking about genetic counseling, it provides individuals and families with information on the nature of how genetic transmissibility could occur. And this, in one way or the other, could affect choices when it comes to who you can marry, how many children you can have, and very many other reproductive issues. And as well as how can we cope with it? Genetic counseling is able to handle such issues. But despite that genetic counseling is very imperative, we need to also know that there are certain psychosocial and ethical legal issues that could complicate the efficacy, the effectiveness of our genetic counseling activity. And if we're not careful, this could impact patient autonomy, could affect healthcare accessibility, attitudes of not only members of the family, members of the society, the economic world, and the larger economic society could, in one way or the other, project the attitudes into the manner by which they perceive and handle and relate to people with genetic related issues, specifically sickle cell disease in this context. So, but why do we need to really talk about, see issues, ethical, legal, social issues in genetic counseling for sickle cell disease? There's a publication, and that was about 10 years ago by Balkin et al. And within the ambit of that publication, they made us to know that some heritable conditions, when we do genetic testing, we will be able to provide powerfully predictive information about the individual's future genetic status. This is important for us to know. So it means if through genetic testing we can predict what will happen now and later in the future, there are implications not only for the person that is undergoing the testing, because of the genetic nature of sickle cell disease, it could have collateral risk or damage to family members, and by extension, members of the community or society. So we as professionals, as physicians, as psychologists, as nurses, as physiotherapists, as hematologists, we need to be mindful. We need to know that the predictive nature of the outcome of genetic tests that we have information about, we need to manage such information in such a way that those who should not even have access to that information should not have access to the information. And at the same time, we should be able to balance who should we share information with, under what conditions should we share the outcome of genetic test results with. So these are some of the things we need to know because of the predictive power and the nature of genetic tests that people do, take, and of course the impact that it could bring when it comes to the psychological wellness of those that are potentially predisposed to genetic tests, and by extension predictive nature transmissibility of sickle cell disease. So apart from Boskin's presentation or publication, we also need to know that genetic information about an individual provides information not about that client alone, but says so much about the characteristics of immediate members of the family, the proband. So the family or kindred nature of genetic information poses ethical and social challenges for the appropriate management of that information in clinical and research contexts. So it's not only when it comes to the issue of dispensing care, even when we tend to conduct research among people living with sickle cell disease, there are several ethical, legal, and social issues that are involved. More so, people with this kind of condition, they are vulnerable in research, vulnerable in clinical care. So it is our duty as specialists, as physicians, as nurses, as psychologists, as hematologists, to become the advocate for people living with sickle cell disease, their parents, their family members, at the same time too. And not only that, we should, as much as possible, do what I will call the therapeutic use of self. That is creating a therapeutic milieu. That is making an environment that will make your therapy to become efficacious, making sure that bottlenecks are removed, making sure that attitude issues that could make people living with sickle cell disease to feel as if they're not valued, to break those barriers, to give them a kind of atmosphere or condition, environment that will make them to feel loved and to feel being supported. And of course, therapeutic use of self in that context will demand that we should become the eyes for the blind, and we should become the legs for the amputees. So still talking about this, sorry, just a moment. Okay, so we need to specifically mention what are the specific psychosocial and ethical issues that we could encounter when we are dispensing, giving, implementing genetic counseling activities, schedules, and programs for people living with sickle cell disease. When it comes to psychosocial, there are a lot of issues that relate to stigma and social discrimination. Dr. Ofakunrin a moment ago mentioned some of these issues while he was presenting, and I need to say we cannot overstate it, that stigmatization and social discrimination are some of the major issues that people living with sickle cell disease are often exposed to. And of course, because of the nature of the condition and the nature of disease and symptomatology, oftentimes people living with sickle cell disease, as well as their immediate family members, they could suffer emotional and psychological challenges. In fact, very many times it places them in a kind of psychological turmoil. And of course, very many times cultural and religious beliefs are in one way or the other, could impact not only an individual's capacity to cope, but even the prognosis and the tendency for tenacity to feel that they can deal with the condition. Because if cultural issues, if religious beliefs are positive, it could complement. But if they are negative, as we find in very many settings and communities, it could be very, very, deleterious. And of course, there are very many socioeconomic barriers that could come with a circumstance or a situation of being diagnosed with sickle cell disease. And apart from this, psychosocial issues could directly or indirectly intertwine to bring ethical issues also in the context of providing genetic counseling for people living with sickle cell disease. And some of the issues that we are going to look at in this lecture will include autonomy issues, and of course, how that also affects informed consent process. We'll look at that also. We'll also speak about confidentiality and privacy, trying to identify the similarities and differences in the two concepts called privacy and confidentiality. And apart from that, we'll also look at how these could, in one way or the other, affect reproductive rights and genetic selection among people living with sickle cell disease vis-a-vis healthcare workers that, in one way or the other, are given the responsibility of watching over, of coping, of treating or managing patients' symptoms. So I will speak first on stigma and discrimination. Individuals living with sickle cell disease often experience social stigma, and of course, people could perceive them, people living with sickle cell disease, as unhealthy. People could also label them as sickly. And of course, people living with sickle cell disease may be isolated economically, socially, culturally, or psychologically. So it's our duty for us to appreciate that these are some of the potential problems that people living with sickle cell disease could face. And knowing that is not it's just only sufficient, but we should ensure that we bring in mechanisms, measures, programs, activities that will tend to make them see the need to live and also support them to cope with some of the societal attitudes or issues related to discrimination and stigmatization that they may face. And when people are isolated, it could affect their psychological well-being, at times also opportunities that will be available to them and the extent to which they can access, available opportunities in their immediate and surrounding environments. And people, and especially in some communities, they associate sickle cell disease with bad luck. I guess it's the paper of Adewale and the group that Prof. Ofakunrin was also referring to in the lecture that we just listened to before this one. So people perceive in some parts of the world, in some communities, and do I say also in certain areas, that when you have a child with sickle cell disease, that child has brought ill luck to the family, and that child could be a minus to the overall psychological well-being of the entire family. So such young people, such children, such patients living with sickle cell disease could be discriminated against when it comes to marriage choices. And not only that, there are certain employments that may not be made available to people living with sickle cell disease because of discrimination against them. And of course, people also may not have enough education to know that living with sickle cell disease does not really end one's life story. As Professor Dr. Ofakunrin said a moment ago, I have had classmates who were, sickle cell patients, and they actually perform better than any student in the entire class. There are several age, stages of my educational, exposure. I have seen very many of them. Whether it's a compensatory attitude or whether it's nature's way of paying them back, I still do not know. I'm not sure we have conducted enough studies in that area, but the much I know by observation and by experience is that there are several people living with sickle cell disease that are very, very cerebral, very, very strong academically. And for that reason, people shouldn't just globally label, stereotype that people living with sickle cell disease, that they are minuses in our communities. No, they are not minuses. They could be even better products. They could be better species. And we need to drum that very clear. Okay? I'm not saying on that ground that you go encourage people with AS to marry AS. I'm not saying that. Neither am I saying that someone living with SS in terms of genetic status will not be mindful in terms of marriage choices. No. But if it has happened, it has happened, like Dr. Ofakunrin said a moment ago. How do we live with it? To be able to get to the peak of our game, that should be our focus in terms of supporting people living with sickle cell disease. And of course, stigma and discrimination, they could contribute to the reluctance of affected individuals to disclose their carrier status, and this could reduce effectiveness of genetic screening programs. So if you know that you'll be discriminated against, or if you know that you are going to be labeled or stereotyped in one way or the other, chances are that you may not be willing, you may not be forthcoming to openly say that you are living with sickle cell disease. But if you know that this environment is going to be supportive, the society is going to receive you, chances are that you'll be bold enough to say, this is my, situation. And for as long as, you obey some of these nutritional things we talked about, maintenance of health, wellness, psychological balance, one can still live with sickle cell disease and live to the peak of one's, lifespan. Although people will say that many patients living with sickle cell disease may not fulfill their lifespan compared to others, I beg to differ, because I've also seen people that live with sickle cell disease and they advanced so much in their age. So it's not sufficient to say that because someone is living with sickle cell disease, and on that ground, that means the person may not, live to the extreme of their age. The answer is no. So there are cultural and religious beliefs that people also could, in one way or the other, associate or attribute to a condition of sickle cell diagnosis. And of course, this could significantly influence people's attitude towards genetic counseling if the culture, if the environment is such that there's a kind of perception that people living with sickle cell disease, that they're from a different world, or they are leading with witchcraft tendencies, that would be deleterious. People could have that kind of a cultural disposition or that kind of a religious belief, but it's our duty in genetic counseling to disabuse the minds of people, and also through collaboration with other non-government organizations and through entrenchment of positive policies, to be able to educate people, to be able to correct some of these myths and misconceptions arising from their religious perception and cultural dispositions. And some communities, genetic counseling before marriage is discouraged because it is perceived as interfering with divine will. In other words, we believe and we advocate that whether in mosques, whether in churches, whether in traditional practice settings, that the issue of genetic counseling before marriage should be encouraged. But some people who could also, in one way or the other, tend to be holier than the Pope, tend to believe that if you subject yourself to genetic counseling and you are insisting on ensuring that this is the kind of person you can marry, this is the kind of person you cannot marry, Some people believe that you are, by extension, you are trying to, contest with God's divine plan for your life. That if God has said that this is your spouse, whether the person is, having AS or SS or whatever genetic status the person is, that doesn't matter. No, some people could say that that contradicts God's will. No, the same doctrine, let me say biblically, also say my people perish because of lack of knowledge. If priests do know that if you give correct counseling to people, that could reduce the transmissibility of, bringing up a child or offsprings with, sickle cell disease. If people that are religious leaders have that information, it will help in strengthening people's attitude and disposition and tendency and eagerness to participate in genetic counseling and genetic screening before marriage, so that people that have predispositions towards, raising up offsprings with sickle cell traits and conditions will be reduced to as near zero as possible. So faith-based healing can also lead to reluctance in accepting medical advice and, of course, genetic counseling recommendations. Some people will believe that, I know God will do it. And some of these God will do it positions may contradict what we have established over the years in science. I'm not saying that we can contest what God will say. I'm not saying that. But when science has sufficiently established a fact, we should at the same time, even within the context of our religious practices and beliefs, accommodate science within our, spiritual dispositions. So these cultural perspectives could pose challenges to healthcare providers in delivering effective genetic care counseling services. So where people believe that, you are trying to contest God's positions or wish, by insisting on scientific predispositions in trying to determine who you can marry and how one can live one's life. So these are some of the things we need to, put into consideration. So it means people that are religious leaders, they will need a little bit more of education, so that they will not also miscounsel or mislead their followers. So, for example, in Southwest Nigeria, people have different perspectives about and perceptions about sickle cell disease. And of course, this is shaped by our differences in cultural beliefs, medical knowledge, health awareness, and social expectations, and of course, some traditionalist views and some traditional views associate sickle cell disease with spiritual causes. Some believe that it's because of one's enemy, or because one was bewitched. These are misconceptions. And of course, very many times they have no scientific foundations. Okay, modern science empowers that genetic inheritance and medical management are things we should consider, and we should share this information with people that are community leaders, religious leaders, even though they may have a hold sway when it comes to swinging opinions and decisions among people in religious communities. Also, additionally, there's the limited public awareness very many times. And when people are not aware what genetic counseling could offer, chances are that they may not, in one way or the other, access or utilize, genetic counseling services. Many affected families oftentimes also do not receive proper guidance on issues related to marriage, on the issue related to, the manner by which sickle cell disease could be transmitted. So they could misinform other people, and also institute unhealthy disease management strategies in terms of the nature of herbs, in terms of the nature of cultural, practices, religious practices that they will prescribe. I'm not saying your spiritual bath or spiritual incantations or things like that may not, help to solve some social issues, but we need to know that if there is a position entrenched in science, we should, in one way or the other, consider that when it comes to planning of interventions, preventions, of transmissibility of genetic counseling for people living with sickle cell disease. And of course, there should be initiatives to educate communities so that people will feel inclusive in their practices, in the ways lives are run. There's something we call the HIA. The HIA here means in anything we want to do, we shouldn't close the space for other people with challenges from being included in our plans. The here means diversity, equity, inclusion, and accessibility. And this is important so that people that are in one way or the other vulnerable, or that are living one form of challenge or the other, will not be excluded in the run of things, that the limitations and bottlenecks along their pathways should be removed, so that they will be able also to have equitable access to resources of treatment, of care, of prevention, of various levels of management. And of course, in southwestern part of Nigeria, some people believe that those who have sickle cell disease, that they are people that will be alive today and dead tomorrow. They called it Aisafoniku for Lande. That means today they are well, the next day they are not well. This could be discriminatory, and this could be stigmatizing. And of course, some people will also call it Aisanwolabi. Aisanwolabi in the sense that, for anyone who has this kind of condition, it means the resources of the family will be deployed in taking care of that person, that individual living with sickle cell disease. We need to know that if family members and community members will support people living with sickle cell disease and there is positive health habits, chances are that an individual with sickle cell disease may not even fall sick and may not have malaria often, that could complicate other symptoms or other conditions that the sickle cell patient may be suffering from. So if there are supportive health services from the immediate and larger community of the patient living with sickle cell disease, the person may not fall ill too often, and by so doing will no longer be Aisanfoniku Folande or Aisanwolabi. Aisanwolabi in the sense that the resources of the family will be deployed in taking care of this person. But if prevention is instituted to ensure that this person doesn't fall sick often, there's no need thinking or expecting that the resources of the family, finances, will be deployed exclusively towards taking care of someone living with sickle cell disease. And of course, there are also social issues and socio-cultural barriers that may, in one way or the other, act as hindrances. There are financial constraints and inadequate health and care infrastructures, and this may, in one way or the other, be extendable to people's access to genetic counseling services. So many communities, many governments do not even prioritize health in the first instance. And where governments, communities, societies don't prioritize health, it could, in one way or the other, affect the attention of those governments to the institution of genetic counseling services in terms of accessibility and affordability to people in communities. And of course, some governments, depending on where you find yourself, if they are sufficiently wired to care for the health of their people, will break the barriers that will not make people to access all areas of service of preventive management. And some people will focus on tertiary level of management. When governments focus on tertiary level of management, chances are that they may not deploy enough resources towards preventive management, inclusive of preventive services such as genetic counseling opportunity. Do I say that Many governments don't even know that pre-test counseling, genetic counseling should be prioritized. They feel that if the condition is diagnosed, we can always prescribe, we can always treat. But prevention is better than cure. And many Nigerians also may not be able to afford genetic testing or counseling, not only Nigerians, in other low or middle income countries also. And when they are not able to access genetic testing and genetic counseling services, it may be difficult to be able to make informed reproductive choices, because knowledge is power. The more you know, the more you're able to use that information to make profitable decisions. And of course, rural communities also face a shortage of trained genetic counselors. And this is not only in the area of genetic counseling, in very many other areas of specialized services. Look at surgical services, look at other, state-of-the-art, therapies that are being developed day in, day out. How many of these things do you have in remote locations? Many times, those facilities are concentrated in urban centers. So, those living in remote areas, in rural areas, they may not be able to access such facilities. Addressing these barriers require government intervention, and of course, in also healthcare budgeting and funding, and also to decentralize genetic counseling programs. So advanced therapies such as bone marrow transplants, for example, and the hydroxyurea that was mentioned by Dr. Ofakunrin, they may remain inaccessible to most patients because of the cost, because of the special professionals that are required to deploy these services. So it may become a source of barrier such that people may not be able to access those facilities where they are concentrated in eyebrow areas. And of course, when we are talking about limited access to care, many patients even cannot even, buy preventive treatments, drugs to prevent malaria. And some people also, in terms of nutrition, are not able to feed well. And there are some of the barriers that could make, the issue of the health, the overall well-being of a patient with sickle cell disease to become compromised. And this raised questions about equity, and also that the government need to subsidize certain aspects of genetic counseling services and sickle cell disease management. Also, we need to talk about resource allocation. Resource allocation in the sense that the resources that are available in a community, how are those resources shared among all and sundry, such that people that are in one way or the other more vulnerable are given attention. And this is why equity is a little different from equality. So in equity, you are looking at the conditions, the limitations, hindrances that may not make an individual to get to the peak of his health or to the peak of his potential. But if we're talking about equality, we are saying that there should be similar standards that will be deployed, allocated to all and sundry. This may neglect the peculiar needs of people living with sickle cell disease. We need to factor that people living with sickle cell disease may need a little bit more of attention in terms of prevention, in terms of secondary management, and occasionally when it comes to tertiary management, like in bone marrow transplantations in some instances. And of course, there should also be efforts to improve awareness, policy frameworks, and healthcare practices that will be very, very optimal in addressing some of the challenges that I've talked about. Now, what about legal issues that are inherent in genetic counseling for patients living with sickle cell disease? There are several issues that could arise looking at the legal dimension of management of sickle cell disease and genetic counseling for sickle cell disease. When we say legal, what does it really mean? It means it relates to the law. That is, in a country's constitution, you have written guidelines concerning your behavior, your comportments, and these are things that must be done. And this is the dividing line between ethics and legal. In ethics, we are saying what you should do, what you ought to do. But in legal, we are saying what you must do. So when one contravenes legal standards, there are punishments. But when it comes to ethical standards, very many times there are no, definable punishments. But that does not mean that in certain communities that there are no subtle community punishments for flouting ethical standards. Like in the southwest part of Nigeria, I can remember a singer in the 70s sang, ohun tí ò dá má gbàyàwé ọ̀rẹ́ ojú ló fi ń tini. That is, what is bad is bad. Don't snatch the wife of your friend, okay? That it brings shame. So that's talking about morality. That's talking about ethics. But that's different from what the law prescribes, saying that if you steal, you will be punished. And of course, if you commit a crime, there's a penalty that will be waiting, written in the Constitution. So it means even though a few things could be legal, they may not be ethical. A few things also could be ethical, they may not be legal. Look at, for example, the issue of abortion. Abortion in many European countries, abortions are legal, but is abortion moral? Because there's a tendency for some also to feel that when you abort, you are indirectly killing a nation, killing an individual that is developing. But I don't want to take us to the full discussion in the area of ethics this morning, because that will lead us into another area we call personhood. In other words, we'll ask the question, who is a person? Because the definition of who is a person will make us to know whether the fetus that is in utero, when it's aborted, whether we have actually hurt anyone. Let's leave that discussion till another day, so that we don't go into the ocean of Bayesian confusion in the area of ethics. So ethical issues appeal to a moral judgment, things we ought to do. It may relate to what is legal, but it's not coded, neither is it written as you'll find the documents in a country's constitution. So now specifically, looking at legal issues in genetic counseling. For genetic counseling for sickle cell disease in Nigeria and Ghana, there are complex legal and ethical concerns. And not only in Nigeria and Ghana, in many other climes anyway. So in Nigeria, there are several states such as Anambra, Kano. They have, in one way or the other, developed modalities for people to know what to do in terms of premarital genotype screening to reduce sickle cell disease incidence. And of course, these laws aim to protect public health, to raise human rights concerns, particularly around autonomy, that is, right for people to be able to defend their rights, right for people to be able to say this is what I prefer, and also people to make decisions based on adequate information, and also to affect to reduce the risk of likely discrimination. And that was published by the Nguvu Collective. That's in 2024. Okay, so there are laws that have been promulgated. There are guidelines, there are policies that many communities, many countries, many states are doling out. And for example, in Nigeria, there's a state we call Anambra State. In Anambra State in 2019, there's a law that prohibits marriages between individuals with incompatible genotypes. And of course, some people believe that even though this law is in place, some people are advocating that also may infringe on their personal freedoms and reproductive rights. In other words, someone could know that the person that I love so much, that is the love of my life, is AS, and that I am AS doesn't disturb me from marrying someone that is AS. But the law is saying that when you find yourself in such a situation, and you shouldn't go ahead to contract that marriage. But others may argue, it's about me, it's not about you. I can choose who to marry, and for as long as it's okay with me, what concerns you about it? But again, this may also take us to the dimension between autonomy and overall community welfare and safety. That takes me a little bit again deeper into the domain of moral philosophical judgments. For example, in the domain of deontology, we have a duty as genetic counselors to ensure we share information with people and make them to know the implication of the information that we are sharing with them, how this is going to impact their life choices and overall well-being later in life. Okay, that's one perspective. We as genetic counselors have that responsibility. But Kantianism, which is another fallout of deontology, is saying that inasmuch as we believe that we have a duty to share that our intentions should rather be prioritized over the consequences of our actions or decisions. So this leaves us with a little bit of, gap in between. Do we obey our intentions, or do we do we obey
Prof. Adejumo, please, you've muted yourself.
Oh, sorry. At what point in time did this happen? Can you bring me back to book?
No, just about a minute ago.
10 minutes.
No, 1
Oh.
minute, just about a minute. So,
yeah. Okay. So I was trying to separate, do a moral philosophical dissection. And I was trying to say that two moral philosophical theories or positions become necessary here. I talked about deontology. I talked about Kantianism. And I said Immanuel Kant was the one that propounded Kantianism. And it's also in line with deontology, where deontology is talking about duty of we genetic counselors to share information with our clients so that they can use that information to make informed choices, that we are duty bound to share information. But within the ambit of deontology, Kantianism, that is very, very close to deontology, is also saying, based on the position of Immanuel Kant, that our intentions, they should be prioritized over the consequences of our action. And I said that also may leave us with a kind of, do I say, a kind of challenge, a moral burden. Because, for example, a consequentialist would say that the intentions may be good for as long as the consequences of intentions don't bring what is preferred, that intentions will not count. That the consequences of your action will be what will make us to judge whether your decisions have been morally sound or morally absurd. Okay? So, to a consequentialist, it means we need to share information with our clients for them to know that their intentions to marry whoever they like may have an impact or a negative consequence that may resonate not only now, but in many, many other generations to come. In other words, what we are seeing as being, defending our autonomous right today may resonate to the overall evil or, pain, not only in your own generation, but in generations to come. Because you'll be potentiating the gene or the trait that is, in one way or the other, perpetuating a society or a community or a family's tendency to multiply the number of potential people that will come down with genetic issues, specifically sickle cell disease in this instance. And again, by an extension of consequentialism, people like Kenneth Arrow, they have also argued that we should be mindful that any decision, even though we are saying the consequences are good, but the consequences must be that which will yield the greatest good for the greatest number of people. In other words, our decisions today to marry or not to marry an individual may not only affect us, but may affect very many more people. And if it's going to affect very many more people, the intentions may be good, the consequences, not only now, but in later life, and in the lives of a larger number of people, may be deleterious, may be painful. So we should, as much as possible, be mindful that decisions we make today, they are not that which is going to translate to a multiply effect of the pain and the hazards that will come with not being careful with the nature of person that you marry. So these are issues. In other words, the laws are there, but there could be a clash between ethics and law now when we look at the promulgation of some of these laws in certain parts of Nigeria, Ghana, and some other countries. I've just said that in Anambra State in Nigeria, there's a law that prohibits marriage between individuals with incompatible genotypes. And this may be seen or perceived to infringe on personal freedoms. But again, even if it infringes on personal freedoms, it is some people also have also argued that it may not be too bad to, in one way or the other, hurt only one person. But for as long as you don't hurt many more, hurting one person may still be morally sound compared to hurting many more. So the implication or application to genetic counseling is that even if someone feels that his rights is being affected by the nature of these laws that are being doled out in some of these states, we should also balance it with counter information to know that even if we, in one way or the other, affect your autonomous power of deciding of what to do with your life or your body, but the implication to the larger community and the consequences to the larger number of people should be what we should give consideration to on a longer basis. So, for example, also in Ghana, there are ethical debates which center on prenatal diagnosis and selective abortion, which some people view this as morally problematic, given the improved prognosis of sickle cell disease today. As said earlier, people could have sickle cell disease and still live to the peak of their career, the peak of their game, and optimal wellness. So we wouldn't say because we have diagnosed through amniocentesis that this patient has a chance of coming down with sickle cell disease, and for that reason we are suggesting that the pregnancy should be aborted. Some people feel that it's not in all instances. Some people could still have sickle cell disease and also live to the peak of their lives. Okay, so asking people to abort, to some they feel that that's an erosion of their autonomous rights, and they feel that it should be hurtful. In other words, it's like killing, someone else by aborting. So these practices challenge the balance between reproductive autonomy and society efforts to reduce disease burden, just like I've said earlier. And of course, not only in Nigeria, but also in Ghana, there are many issues related to this, that arise as a result of the amount of information that people have about sickle cell disease itself. And of course, even though the laws are there, whether in Anambra, whether in Kano, whether in Ghana, the extent to which those laws are even enforced, that also raises another question. The laws may be there, but the extent to which those laws are enforced, that also becomes another issue. Just like in Nigeria, for example, you need to, when you ride on your motorbike, the law says you should use your helmet. But when you see people on streets, on highways now, how many people do really wear, helmets when they are on their motorbikes? So the law is there saying that you should not ride your motorbike without a helmet. But people still ride motorbikes without helmet. How many of these people are actually punished? That's another point for debate some other time. So the lack of legal standardized national framework in Nigeria and many other places have led to a fragmented implementation and confusion. And efforts like the Sickle Gen Africa, they emphasize the need for community engagement, ethical oversight, and patient-centered policies in genetic counseling across Africa. And we also need to know that some genetic test results may reveal information regarding the disease of other biological family members. So this is a legal issue here. Do you have the power to disclose that in my family, everyone is, SS? We need to be mindful. We need to be careful because other members of the family could also sue you, bring up, legal issues against you if you go ahead to disclose. You may have the power to disclose, But if you disclose information that could be injurious to your immediate biological family members, that could also lead to legal issues. Addressing legal gaps is essential when it comes to managing the gap between individuals' rights and as well as community and family rights at the same time. So, family members, should they be informed of test results? If you now realize that you have a diagnosis of, SS, HBS and other things like that, of or who should be the one to pass the information? Is it the physician? Is it the counselor? Should the individual diagnosed with a genetic disorder inform his or family that may be at risk? Are you under any obligation to disclose? This could become social legal issues. Alternatively, is it the physician who conducted the result, who has the result that will do the work of whistleblowing? These are things that we need to clarify, especially within the ambit of laws and policies. But one thing remains clear: you cannot share an information with someone else if the owner of that information has not given you that power to share that information with someone else. And if you have information about an individual's genetic status, that may raise paternity issues. Of course, and some people also could, as a result of that, self-blame, and in one way or the other, some people will begin to think, even though I'm in a marriage, should I think of having raising kids or not raising kids at all? And if now I realize that one out of the three of my children is sickle cell patient, should I will part of my life earnings and life belongings to this patient that may die, sooner than expected? Or will you, as a result of compensatory behavior, want to share part of your life earnings and belongings to this patient that is sickle cell positive? Do you want to do that as a result of compensatory behavior? So social legal issues may arise. And of course, I'm not sure there's any textbook that will carefully dissect this and make prescriptive, judgments concerning the way we handle some of those issues. In other words, we need to manage and balance such issues based on the peculiarities of each situation and circumstance. So, some people also may begin to raise legal, personal, ethical, legal, moral questions concerning whether it's necessary for me to even participate in genetic counseling. But I must say, whether it's written or not written, whether in Ghana, whether in Nigeria, and many parts of the world, participation in genetic counseling, participation in genetic testing still remains voluntary. And both countries, whether in Nigeria or Ghana, they have launched newborn screening initiatives like the CONSA to improve early detection, where CONSA is consortium on newborn screening in Africa and to improve early detection. And of course, Ghana has announced plans to expand screening nationally, but there's no law yet that enforces mandatory testing, even in Nigeria or in Ghana. And of course, there's rumors of compulsory DNA testing, which have been debunked as not true in the recent past. There are many other social legal issues that may arise. We need to know that competent adults have the right to choose whether or not to undergo genetic counseling and testing. So it's just by persuading, encouraging people, not by making it a point of compulsion. And before making decisions, people that have people have the right to be informed of the nature of their condition and its prognosis, potential risks, and benefits of a proposed test or treatment, and that the alternatives to post-intervention must be carefully shared with people that are participating in genetic counseling or testing. And healthcare workers may be held liable for not giving adequate information that a genetic test is available. So, and of course, even also you as a professional, if you do more than due diligence in terms of sharing adequate information, you could also be liable. So there are very many, risks that go with genetic counseling and testing. Okay, and some of these could be psychological, social, economic, legal, and physical. In terms of psychological, knowledge about deleterious mutation may bring distress, including a diversity, anxiety, denial, anger, and depression. And this reminds me of the middle 90s, while HIV just came. I don't want to mention the institution, but there was this military officer. He came to the teaching hospital wanting to conduct, HIV screening. And of course, the person, the officer that was in charge, Ajayi, mute yourself. Oh, somebody's microphone is left on and it's interfering. So I'm recounting an experience in the middle 90s. I'm recounting an experience in the middle 90s where the military officer came for HIV screening. And the healthcare worker in charge of that, at the end of the testing, just brandished the result. Oh, they told us that you are positive. Oh. You say they, without any counseling, no pretest counseling, no counseling concerning availability of services and what to do after testing positive, nothing like that. Of course, the officer collected the result from the healthcare worker. But between that hospital and the army barracks, he used his own service pistol to kill himself. So someone who also has just been told that he's, having sickle cell disease, someone like that could run into a psychological turmoil and may, feel depressed and may become acutely psychotic. So also there are social implications, social risks that will go with counseling or being diagnosed with, sickle cell disease. Somebody could start thinking, oh, one may be isolated, one may be also ostracized. And of course, this could also challenge previously held beliefs and taboos and myths. Maybe people have told you that in your family, no one can come down with any form of illness or disease. But now that you have tested positive and we realize that you have sickle cell disease, that could, in one way or the other, make such an individual to feel betrayed by what he learned about the culture and the taboos and myths that had been, shared with him from infancy. And of course, when one is now diagnosed with a condition of sickle cell disease, could be tilting towards spiritual warfare, either to read Psalms or to fast and think that when I fast, that will make the the genetic trait to change. I know there's nothing God cannot do, but or maybe other ritualistic practices, or to go to bath at the stream, or to do one kind of ritualistic practice. It may not work, and it's not in all instances that it could work. We need to let people know that. And socially, being diagnosed also could, in one way or the other, affect one's perception about the social role. Now that you know that you have a disease called sickle cell disease, your role in the society may begin to diminish if people also get to know that you have a sickle cell disease. Whoever is hiring you will be careful also to know the kind of roles they will give to you in your place of work. Take for instance, like we talk about English Premier League. If one had been playing before, but no one knew that he was positive or had sickle cell disease, maybe after his screening, going from one club to the other, and sickle cell genetic testing was done, and we now get to know, that may affect the rating, that may affect the value, that may affect the nature of roles and perception and status that will be accorded that kind of an individual that is now testing positive at that point in time. Of course, economically, insurability will become worsened. The economic premium, the insurance premium also could become worse. Employability could become reduced if one has been diagnosed with sickle cell disease. And cost of follow-up and lifelong treatment, the implication also may become so much economically overwhelming. And legally, very many times, one could be at the quandary of, should I disclose to my employer or to community that this is my genetic test result outcome? And of course, but physical risks may not be that common in the perspective, in the domain of, talking about risk related to genetic testing and genetic counseling. Okay, so in terms of ethical considerations, in genetic counseling for sickle cell disease, I shared some of these ones earlier, and it's nice also for us to know that genetic counseling should empower individuals to make informed choices. That is, give adequate information upon which people will be able to make meaningful, sound decisions. Okay, but if you do not empower them with information, you have deprived them tremendously. So it's nice for us to know that it's the autonomous right of people that come to us for care to have adequate information upon which they will be able to make sound decisions. But in Nigeria and many parts of the world, societal and familiar pressures often influence decision making, limiting personal autonomy. In other words, even though you know you have the autonomous right to make a decision, but the church, the mosque, the religious leaders, society members, gatekeepers, they could, in one way or the other, still swing decisions. I've seen circumstances whereby it's the father in a family that will always prescribe who their daughters could marry, even though they may have differences in opinion and perception. But when the father says you cannot marry this person, you cannot marry that person. That's the way that family has been running. And this could, in one way or the other, affect, the individual right of that person to be able to make decisions that are in accordance with his own values and preferences. And we also need to mention that ethical genetic counseling must ensure that patients receive sufficient information and that we are giving them enough freedom to be able to make decisions without being unduly influenced, without coercion, without being lured into making any decision. So the issue of confidentiality also is another issue that I'll quickly talk about. Informed consent before testing and sharing results is important, but we must ensure that we store such information very, very securely. And we should limit access to people who will have, contact with that information. It's only people that have been authorized by the owner of that data that should be given the right to have information about that patient or that condition. And if the patient identifies right from the beginning, so that people cannot directly link, an individual's data to his name, to his community, to his family. And of course, we must be careful even when we need to disclose to family members or people that are, related to that person. We only do that when it's ethically justified, when the individual is giving you the right to share that information with someone else. And of course, to do this, we may store information in passworded computers, genetic counseling information during testing, store such information in passworded computers. You can save it also in the cloud so that people cannot just bump into that information. You can also save that information in relevant files and locked up cabinets, and you can de-anonymize in some instances. But also you can do encryption. There are a lot of other things you can do to ensure that you assure confidentiality. I need to let us know that there's a little difference between privacy and confidentiality. Privacy is the extent to which you want to share your personal information with someone else, okay? The right to have control over who will have information about you. That's privacy. But every bit of what we do to ensure that we disallow people that have not been empowered or allowed to have information to specific information, when we build in mechanisms to ensure that whoever shouldn't have information is not, will not stumble into that information. That could be issues within the ambit of confidentiality. Okay. And there are many other things you can do, even legally. Like in the United States, there's something we call IPA rule. And of course, in the United States, if it's in the area of genetic counseling and genetic research, okay, there's something we call COC, if it is to relate with the National Institute of Health. COC is Certificate of Confidentiality. In other words, you go deliberately to take a kind of legal permission that you will not share this information with someone else, even if you are being compelled to do that. So there's the HIPAA rule, and there's also the certificate of confidentiality. So some individuals may opt for termination of affected pregnancies, and of course, it could spark debates on morality of personhood and genetic selection. In other words, are you saying it's a specific, genetic trait that you want to potentiate in a line, in a family, in a community? Some people could also argue that there also may not be moral. Genetic counseling must provide balanced information, ensuring that individuals, people understand all options without coercion. So, equitable access to genetic counseling, meaning that there should be fairness in treatment, access and opportunity by addressing systemic inequalities. Okay? And ethical concerns arise when genetic counseling services remain inaccessible to marginalized populations. So populations that are marginalized, ensure that we take care of them, make sure that we do more than the necessary call to duty to ensure that their vulnerabilities are addressed. And we need to ensure that equity is the name of the game. In other words, the deficiency and things that may make people not to have the best in terms of access, that you, as much as possible, remove those limitations and boundaries. And of course, how does this relate to principlism? In relation to principlism is a Eurocentric moral philosophical viewpoint to accommodate the weaknesses of extant moral philosophical positions. And when I say extant moral philosophical positions, like earlier I talked about deontology, I talked about Kantianism, I talked about consequentialism, I talked about utilitarianism. Each of those ones, they are good, but very many times they have their deficiencies. Okay, they are not perfect. So principlism is a middle of the road approach to ensure that the imbalances and the nuances and the weaknesses in extant moral philosophical positions are addressed. And when we talk about principlism, it is four of a kind. In other words, we're talking about autonomy, we're talking about beneficence, we're talking about non-maleficence, we're talking about justice. What do you mean by autonomy? Autonomy is a combination of two words, auto and nomos, right to self-rule, right to self-governance. In other words, we need to respect people, give them adequate information. And of course, this is applicable when it comes to informed consent-seeking process, in pre-test counseling, post-test counseling, and when it comes to issue of privacy, confidentiality, and disclosure of test results. When we enforce those ethical standards that I've talked about so far, then we'll be protecting the autonomous right. And I've said that principlism has four major domains, so four major subparts: autonomy, beneficence, non-maleficence, and justice. When we talk about beneficence, you as genetic counselor, every bit of what you want to do should add betterment, improvement in quality to the person that is sharing your information or counseling or you are treating. So any treatment that is not going to add value, any treatment that is not going to bring benefits, it's immoral. It's not in agreement with ethical standards. Of course, as early as 400 to 362 BC, Hippocrates already say that we as specialists, not only physicians, counselors, physicians, healthcare workers, above all, we should not do any harm. So we should be mindful of the nature of words we speak or we share. There's a difference between talking with and talking at. So mind the language you use and the approach that you deploy in such a way that you will be sure that no harm is meted to that person that is consuming your service. And of course, justice is talking about fairness, talking about treating equals as equals and treating unequals as unequals. And it's about distribution of resources. So when it comes to budgeting of healthcare services, how much do you, deploy towards prevention of sickle cell disease? How much do you deploy to management of cases or issues related to the welfare of people living with sickle cell disease? This is still about justice, not just deploying, a greater percentage of the commonwealth to take care of a handful few. Okay, so we should be mindful of who gets what and how does he get it. Okay, but we as genetic counselors, we also need to know that there are certain standards that we must adhere to. Standards relating to competency, standards relating to counselor-patient relationship, informed consent issues, malpractice or negligence, and inclusion of patients in research where conflict of interest could arise. Okay, I'll just run through this very quickly because we are behind time now. You should ask yourself ethically, before assuming the role of an healthcare provider in the business of taking care of people living with genetic counseling. Ask yourself, altruistically, are you competent to render care? Have you gone through adequate training? Are you wired to be able to use the appropriate language to be able to reach out to this client or patient or their family members? Are you competent? You need to ask yourself. Then counselor-patient interaction. We need to also be mindful of this. In other words, there are certain things you do that could, in one way or the other, endear your heart to your client unconsciously. There was the movie in the 70s, The Spy Who Loved Me, James Bond 007, okay, where the lady that was deployed to go and arrest James Bond, a detective, now fell in love along the line with James Bond, and instead of arresting James Bond, rather fell in love, and of course, you can guess what the outcome will be. But we are saying, within the ambit of this lecture, in this class, for we that are professionals, we must be mindful of no erotic relationship should be established between yourself and your client. These are rules, general rules in genetic counseling and counseling for that matter. So you cannot now tell me that that patient that you saw last week is the person you are proposing to or you want to marry, and you are not bothered because he is SS, you are EE, and because so beautiful and you got attracted with the first sight and you want to go ahead into a relationship. That is immoral, that is unethical, and it's not acceptable. Okay? But even if you must do that, it must be 2 years after you have ended your interaction or treatment with that client. And it must be established that while you were giving your care to that client, that there were no, relationship issues between the two of you, and that your judgments have not been beclouded by your infatuation and the love or erotic feelings towards this patient. Then informed consent issues. Oh, this will take us quite some time. When we talk about informed consent, we need to look at the definition of CIOMS, that's Council of International Organizations of Medical Sciences, where CIOMS pronounced in 2016 that, for your informed consent to be ethical, that the elements of informed consent must be there, and that you are sharing information with people that are competent, that are able to understand what you are saying in such a way that you are not infusing them with jargons, and you are saying it in a way that they can decipher, understand, and use that information to make good quality decisions under an atmosphere of freedom without coercion or force. Okay? So that's, in other words, there are elements of informed consent, information of disclosure, competence, that is competence of that individual to be able to understand even what you are saying, okay? And of course, authorization is the approval, or otherwise, decisions arrived at as a result of your sharing of information with people upon which they are making decisions of yes or no, okay? And malpractice or negligence is another thing that we must consider legally and ethically. And of course, for us to prove issue of malpractice, anything that you do that is contrary to standard practices that could come under the ambit of malpractice, we should avoid that as much as possible. Another thing that's negligence, that is every bit of what we do by virtue of the duty that we owe to this client. In other words, if there are errors of omission or commission that has led to one form of harm or the other, the patient will come up to seek compensation, when he's able to associate that the duty of care you have had been compromised in one way or the other, and that has translated to one form of injury or risk or the other, and for which is seeking compensation as a result of your failure to mitigate those risks or to dispense care, within ethical standards. Inclusion, I talked about this earlier. We have to be mindful. Conflict of interest issues are also very, very critical. In other words, if your situation or your circumstance could compromise the nature of judgment you make in a specific circumstance, such that your judgment will becloud rational, moral thinking, that could be a conflict of interest. There could be individual conflict of interest. There could be organizational conflict of interest. There could be financial conflict of interest. There could be conflict of interest in other dimensions. But when you realize that there's the potential for conflict of interest, you shouldn't go into that, interaction or treatment relationship. You should declare your conflict of interest. If possible, exclude yourself and ask somebody else to take care of it. Just like I talked about competencies, there are certain situations. Maybe the patient with sickle cell disease has comorbidities beyond what your training could accommodate in terms of you being able to do a good job. You may need to bring in someone who is more competent or is well wired in that area of anomaly that you have seen. If not to take over, but to complement you in your genetic counseling activity. So also when it comes to inclusion, when you realize that your position will in one way or the other jeopardize ethical reasoning, sound judgment without compromise, then you have to probably opt for someone else or have someone else to take over that management issue. So I've run through many things in the area of ethical issues, as you can find here. So we need to know confidentiality is an important thing. And whatever you have shared with A, if you are allowed to go to B, it could go to C, D, and Z. And of course, genetics is a family affair, and you have obligations to relatives. You have also obligation of relatives. So you must protect family identity, and of course, code patients' information so that people will not unduly be able to understand, have access to what you have written. So if you're not careful, if you don't do all of those things that I mentioned, it could lead to psychological torture. There could be social implications. It could have implications for employment or economic opportunities. Lifestyles may be affected. Obligations to employees may change. Responsibilities to others. These are some of the things. And for anything you are doing, really realize also that test validity must be ascertained. Who is conducting the test? And with what nature of chemicals or reagents is he using? Because there's a tendency to have what we call type 1 or type 2 error. In type 1 error, what is right, you claim it as being wrong. Okay? Someone that is negative, you are saying is positive. But in type 2 error, someone that is positive, that is positive, you are saying is negative. Okay? So we have to be mindful of our test validity. And of course, how do you communicate test results? I've talked a little bit about this. Results should be released only to those individuals for whom the test recipient has given consent. Okay, so in terms of counseling standard practices, you must be competent. I've talked about relationships. I've talked about conflict of interest. I've talked about informed confident issues. And of course, for every bit of what you do, you must document. Any care that is not documented will be deemed not to have been given. And of course, you should be able to disclose whether you have a conflict of interest, and you'll be mindful of what information you disclose as a result of information coming that you are coming in contact with as a result of your relationship with a client. So I'm about rounding off at this point in time. So for any bit of what you do, make sure that your relationship will not impair objectivity, competence, or effectiveness in counseling, and disclose when your counseling role could clash with your role or the role of other financial organization interests. Okay, so I've talked about privacy and confidentiality. Let the patient know ahead of time the limit of your confidentiality, okay? Because there could be other issues that could come with your counseling. If the patient now told you that as soon as leaving your office, is going to commit suicide. If he tells you that, there's an extent to which you can keep that information because that has an implication for life. So in such a situation, you may need to, seek other services to be able to ensure that that patient does not actually execute the suicide. So, and I've said every bit of what you do, ensure that's recorded. And of course, you may not disclose confidential information unless you have the approval of the client. In conclusion, psychosocial and ethical considerations play a crucial role in the effectiveness of genetic counseling for sickle cell disease in Nigeria and elsewhere. Addressing stigma, emotional distress, cultural beliefs, and financial barriers are essential for improving patient outcomes. And ethical principles such as autonomy, confidentiality, reproductive rights, and equitable access must guide genetic counseling practices. And we need to strengthen healthcare policies We need to increase public awareness. We need to integrate psychological support into genetic counseling because this can significantly improve outcomes for individuals and families affected by sickle cell disease. Addressing SC issues in sickle cell disease management requires a multifaceted approach, involving policy reform that we may need to rejig our policies and healthcare practices, and of course, needing to do more of public education. And we need to strengthen extant laws to protect people living with sickle cell disease from discrimination, and so that we can also improve healthcare funding mechanisms and promote ethical genetic counseling. This can enhance disease management not only in Nigeria, but elsewhere. And additionally, raising awareness and reducing social stigma will ensure sickle cell disease patients are treated with dignity and they receive the support that they need. Thank you.
Wow, thank you very much, Prof. Adejumo. That was very insightful and very highly educative presentation. For our participants, I hope that you give us just about 5 minutes to 10 minutes. I know that time is up, but give us 5 minutes to answer a few of the burning questions in the chat box. Okay. So there is one question, Prof. Adejumo, is about concerning the social legal issues. Is it a physician or counselor's responsibility to inform the family? That's one of the questions in the chat box.
No, you have no right to disclose the outcome to families unless the client empowers you to do so.
Okay, thank you very much. And then there's another question about, is it wise for a parent with a child with sickle cell disease to disclose to the child his or her health status, or is it better to refer to the counselor? And then at what age is it appropriate to inform the child of his or her health status?
Oh, thank you for this question. I may need to say it depends on the age of the client that's come for your counseling service. You realize that at younger age, they may not understand what you are saying. But it's nice for you to say, for the parent to disclose to that child early enough for that child to know, so that that child also will have information that will help towards primary prevention and to reduce the risk of complications, okay? And to make interventions effective, okay? So,
Okay.
but the question is, at what age do you disclose? It depends again on at what point in time was this diagnosis made, okay? So, but give or take, my position is that let the patient know early enough. Okay, that's my position. It doesn't harm, it rather helps.
Okay. Okay, thank you very much. There's another question about how do we counsel a mother that always feel aggressive towards a child during their crisis so that the child won't have that low self-esteem?
Excellent question. Because these are things we also see. There's also a blame game. The mother or the father sees that child as someone bringing, ill luck or bad luck to the family. And that may consciously or unconsciously affect the attitude of the mother or the father towards that child. That would rather complicate issues. That will not help the child, and it will not also encourage, the child to cooperate with healthcare workers. Okay, so what the answer to that question specifically is, as much as possible, we need to do not only individual therapy, we may also need to do family therapy. Like one of the cases that I'm managing at the moment, I had to ask for, the parents from a different state where they were to see me on Monday to be able to give counsel not only to that child, but to the parents. Because based on what that child disclosed to me, there are a few things the parents have been saying that are very, very traumatic and are not sufficiently psychologically helpful to this child. It will rather worsen the prognosis. So for the child to become a better person and to still get to the peak of his life, careers, and choices, we need to work patients and family members together to synergize, to be able to bring out the best in that child, so that it will amount to a win-win situation at the end of the day. So, but if there is the stigmatization, the discrimination, the reprimand, the isolation, it will rather worsen things. And the parents will also be affected negatively. So let them know that they have a role to play, just as the child also have a role to play. It has happened. And let them know there are many other people out there that, despite that they are living with sickle cell disease, they are still on top of their game. And I've told you, at almost every point in time while I had schooled, I've had people leading my class that were actually, sickle cell patients. When you see them physically, you know that, something is going wrong with this person. But in terms of intelligence and mental capacity, they were sharper and better than us. And I said earlier, how would you know whether nature was just trying to use that to compensate? Let me leave it like that.
Thank you very much. Dr. Ofakunrin, there is one question for you.
All right, I'm here.
Yeah. Is the use of hydroxyurea age limiting? And then if you start from 9 months, at which age can you get the hydroxyurea? And are there any long effects from prolonged hydroxyurea use?
All right, thank you very much. Regarding hydroxyurea use, that's starting from the starting from age 9 months, that's the recommendation that it should be offered. Then for the duration, for now, is actually expected to be lifelong, except if other therapies are available, and especially the curative therapy that can actually, if the person is cured and no longer have sickle cell disease, then there may not be any need to use hydroxyurea. So, but in the absence of that, then the hydroxyurea is actually a lifelong therapy. Then talking about if being taken for a very long time, what is it not harmful? I think I read it on the chat as well. Is it the complications? So I want to state that there are actually some patients that have been on hydroxyurea for over 25 years, and they are still taking it and they are doing well. And from our own experience, as in even in our center in Nigeria, at least we have patients that have been on hydroxyurea for 12 years, some 12 years, and majority of our patients, they've been on hydroxyurea for 8 years, because we started formally in 2017. So, and it's been a very good outcome. Then I think, still talking about the complications, somebody mentioned that will it not damage the kidney and the liver? So from the research that has been done, so many studies have been done, and even we also have local studies that we intend to publish. So the safety for liver safety and the kidney safety has actually been very good. So we've not actually have cases that while taking hydroxyurea, there's now liver failure or chronic kidney disease or so. So it's actually been very okay. And even as a matter of fact, the protocol, that's the guideline, actually stipulate that even in those with kidney disease, they can actually still take hydroxyurea. It's just that the dosage will be reduced, because they still need it. It's still going to help them. So that is that. Then what have I covered everything about that? So starting children starting
The effects, the long-term effects.
Okay, the long-term effect. So, okay, the long-term effect, the positive aspect, a very great one. At least it reduces, it will help to reduce the clinical manifestation and the complications that is associated with the disease. So that's actually the one. Then I think part of the long-term effect was asking about the side effect. So as I mentioned earlier on, that this is a drug, yes, it was actually discovered as a cytotoxic medication. Then before, it was now found to be useful in sickle cell disease. And as I was always say, there are so many drugs that have been discovered for something else and they find useful for some other condition. So hydroxyurea falls into the same category. So the long-term effect has actually been well, a good one. So not that there are not side effects that are associated. Yes, taking hydroxyurea, at least one of the commonest side effects is that it causes myelosuppression, meaning that the white blood cell count will be a bit low, the platelet count will be a bit low, and even paradoxically, it helps to increase the red cells, as in the packed cell volume. That's the hematocrit. So, but all these side effects of myelosuppression, they're actually beneficial because it's been found that, baseline sickle cell disease patients, they have high level of white blood cell counts, platelet counts, which have been found to be triggers for crisis as well. So being a side effect, now that hydroxyurea can bring that down, it now turns out to be a positive, it's a positive effect instead of it being a negative effect. Then there have also been some school of thought that because hydroxyurea is a cytotoxic therapy, that it can cause cancer, being a cytotoxic medication, that it can cause um, infertility. So all these are actually not completely evidence-based. It's been found, at least from even the experience that we have locally and some other experience, that someone is taking hydroxyurea or those taking hydroxyurea doesn't mean that the cancer risk in them is higher than the general population, meaning that anybody can have cancer, but it's not been found that because some group are taking cancer, hydroxyurea, that there's now more cancer in those group compared to others. So meaning that the cancer causing effect that is being peddled around is actually not evidence-based. Then talking about infertility, studies have actually also been done that some patients were on hydroxyurea, they harvested sperms and harvested eggs and they were placed on hydroxyurea and they were still able to procreate. The women were able to give birth and the men among them were able to impregnate their wives. So we know that sickle cell disease itself is associated with some level of subclinical infertility. So we're now saying that yes, hydroxyurea is now the one that will cause that. What is being advocated is that male or female, if you're on hydroxyurea and you're trying to, bring forth babies, then you can stop hydroxyurea for that particular time, get pregnant and or impregnate your wife and and you continue with the delivery. And even presently, there are studies that are ongoing that hydroxyurea can actually even be used in pregnancy, but not that it's now a general recommendation because some, at least I know that I've read about some studies and I've been in conferences that was presented that those women that were on hydroxyurea before because of pregnancy, they had to stop the hydroxyurea for them as what is actually the current guideline. So, but they started having crisis. So they're now out to restore the hydroxyurea because in that wise, the benefits outweighs the harm that it could cause. But they came out, as in without any problem, the crisis subsided and the outcome of the pregnancy was great. Currently, I know that there's one Professor Eugene in Guy's hospital in the UK that is actually doing a study on the use of hydroxyurea in pregnant women. So generally, putting everything together, the initial fear about hydroxyurea that, oh, it's a very toxic drug, is this, is that, is actually appears to be now very unfounded, that the benefit is so significant and, the so-called risk is not as the way it was portrayed. So thank you.
Okay, thank you very much. There are lots of other questions in the chat box, but we are about 20 minutes past the time. Should we continue? Okay, so we'll take one last question and then we can end it here. Or someone has raised a Tochuku. You can speak.
Okay, thank you very much, Professor. Thank you for the question, the lectures. Okay, I still have some questions regarding the use of hydroxyurea. And yeah, Professor Professor has just talked about the long-term significance and importance of the hydroxyurea, which is very great. I have someone who has been on hydroxyurea for a long time, and for more than 2 years, almost 2 years now, has not had a very serious crisis, just mild crisis, and well managed. Now my question is this: now, is it required that at every given time, or at what time should somebody go for medical checks, something like a urea and electrolyte creatinine test, as well as HPLC, to monitor the usage of hydroxyurea? Or is it not necessary? Should you just continue giving hydroxyurea as long as the person is doing fine? That's one question. Then the second one, I sent it on the chats. A lady I know reacts to hydroxyurea. All right. She said that anytime she takes hydroxyurea, she reacts to it. And because of that, she's always been presented at the clinic having a crisis. What can you advise for this patient to use? Thank you very much.
All right. Thank you very much for those questions. Yeah, very great questions. Okay, so talking about the use of, as you said, that hydroxyurea is actually very great and producing very great outcomes in our patients, and that's the same experience that we have, and people have also been talking about that. So regarding monitoring, it's a drug that needs to be monitored, not that one will just continue to take it without monitoring. So it's expected that while on hydroxyurea, that initially while starting, such that full blood count should be done like almost every 4 weeks. Starting the medication 2 to 4 weeks later, you want to do a full blood count to check the level. But once once the dosage is fully established, because there's fixed dosage, then there's escalated dosage. So once you've established a dosage that you want to continue with, so the full blood count is expected to be done like every 3 months. Then also monitoring the liver function and the kidney function, so that could be done like every 6 months. So, but there are actually current studies and even the experience too that we've actually had that, for the full blood count monitoring, after being on stable dose, it could actually be extended to like every 6 months. A study was done in Kano that they found that, although they used fixed dose regimen, monitoring the patients every 6 months, it's actually, as in every 6 months for full blood counts, is actually very okay. And that's the same experience that we have, although not that we've published that. So that the full blood count that they have at 3 months and the one that they have at 6 months is actually very good. So the renal function test, the liver function test that we do is being recommended at, okay, maybe every 6 months, but we do it yearly. And I want to say that for the past 8 years that we've actually placed our children on hydroxyurea, we've not actually found, someone that we have to stop hydroxyurea for on account of liver derangement or, any liver problem or a renal or kidney problem. So it's actually been a good one. So summarily, full blood count every 3 to 6 months. The liver function test and renal function test can be done annually and it's safe. So, but we don't advise that it should be taken without supervision and without monitoring. So for someone that has been on hydroxyurea, that hydroxyurea is not working for, it's been said, we have different genetic composition. Most patients that take hydroxyurea have actually reported positive outcome with hydroxyurea. So, but it's possible too that there could be some few cases that hydroxyurea may not work for them, but those are very, very in the minority group. So before we say that hydroxyurea is not working, one, the dosage must be actually administered optimally so that you start the dosage, then you may actually try to increase. That's number one. Then secondly, to also ensure that the patient is taking it adequately and appropriately. So that's the number two. Then we need to, that's according to the regulation, at least to wait for like 6 months before you now say, oh, this hydroxyurea is not working. So those are the things there. So if hydroxyurea is not working, eventually after observing all those things, then there are also some other disease modifiers, that's what we call them, that are available that can be used. Although some of them are still in the market, some have some challenges. We know that there's Vosileto, there's crizanlizumab, although all these ones are very expensive. the main one that is actually very cheap or that is affordable, especially to the African population, is still the hydroxyurea. Just that there are additional other disease modifiers, then also trying to take care of some triggers too will also help. So meaning that ensuring adequate health maintenance would also contribute to reducing crisis for such patients. Thank you.
Thank you very much. Thank you, Prof. Adejumo, and thank you, Dr. Ofakunrin, for all the very insightful presentations that you've given us. We'll try, and then the rest of the questions we'll answer it and then possibly put it on the chat box, because we're about nearly 8:30. And so we'll meet again next week at the same time on Friday and on Saturday for next week's presentation. And please, we'll send you the presentations so that you review it as you go on. Thank you for making time, and thank you for giving us extra 30 minutes of your time. God bless you. Thank you, Prof. Adejumo. Thank you, Dr. Ofakunrin, for giving us those presentations.
Bye.
All the best and have a great weekend.
Thank you very much.
Please, LOC, can we meet now?
Thank you very much, sir.
It's when I was having a meeting, I've been doing everything.